I
Not
wish that I was with
okay.
you in person. I have to say, Susan invited me to join you all in May of 2020 for your chosen summit that you were going to have right as the pandemic started. And so kind of thinking about where we've all come over the past 2.5 years, and then thinking about the how special it is that you are all in person together. Again, I hope it's been a wonderful morning so far. I've loved getting to listen from afar, and I'm so sorry I'm not with you. I really appreciate the opportunity to present some of this information virtually, which allows me to sort of balance family responsibilities right now. One thing that I did have the opportunity to do because of the last several years of both recorded and virtual summits is, as I was preparing for my presentation today, I actually was able to sort of do the equivalent of binge watch chosen summits. And I earlier this week listened to really the last 1.5 years of work that you all have done and the progress that you all have made. And so it's so great to be able to continue the conversation and build on some of the previous speakers and talk about something that, as I understand, is really a hotly debated topic in your state, as it is in my hospital as well as in my state. And what I'm aiming to do, it looks like we're starting a little early, which is awesome. I'm hoping to talk for about 35 minutes and then really leave some time for discussion and an opportunity to listen to what your experiences have been in your state. So, title of what I'm going to talk about today is Toxicology Testing in the Peripartum Setting, and really highlighting the unique social and legal consequences for birthing people. I have no financial conflicts of interest to disclose. I do receive funding from the organizations listed for both research and programmatic work that I do. Okay, I'm hoping over the course of the next half hour that I will discuss some of the work that I've done trying to assess the utility of peripartum toxicology testing. And this is going to be really look at 3 different domains. The first is, how do we assess clinician documentation of patient consent for peripartum toxicology testing, and examine to the extent to which patient and hospital characteristics were associated with that documented or lack of documentation of consent. The second is to examine racial disproportionality in toxicology testing, social work evaluations, and child protective services referrals in Massachusetts. And then lastly, think about what is the clinical utility of all of the tests that we order. With all of those findings, I'll share with you what we've done at MGH, the hospital where I work, to think about some pretty substantive policy and practice changes that we made, and then share with you that this is a work in progress, and that, as you know from all the work that you do, that quality improvement work is hard and the arc is long, and to show you where we're at. So I want to start off with some key definitions. This is really building on what Dr. Kranz several years ago in one of your keynotes talked about, but screening is the use of a validated screening instrument or a therapeutic dialogue to elicit information about substance use. What I'm going to be talking about overwhelmingly today is toxicology testing. So that's the collection of either urine, serum, meconium. As I understand in your state, you use cord samples a lot to capture the presence of a substance and or its metabolite at a particular point in time. And then the next thing we're going to talk about is reporting. So using a referral to Child Protective Services for concern for abuse and neglect. And what I think is really unique about the space that we all are so passionate about in the perinatal setting is that often there's this kind of march from screening to testing to reporting. And what I want to hopefully convince all of you, if you're not already on board, is that perinatal toxicology testing has profoundly unique and consequential social and legal impacts. Okay, here's some really just down and dirty basics of toxicology testing. Toxicology testing measures recent-ish exposure. So each substance has a different half-life, which means that the length of time from when someone previously used that substance to whether it's then it or its metabolite is measured in a toxicology test depends on the assay, depends on the substance. And this comes up so much, and I'll just highlight it, particularly with cannabis, because of a very long half-life that cannabis has, particularly for pregnant people with sometimes higher rates of adipose tissue where it can collect. So it collects recent-ish exposures. Most tests that are performed continue to be non-definitive. And what I mean by that is they're quick cut or they're an immunoassay, and they're often not sent for confirmatory testing, but these are actually preliminary tests that require confirmation. The final, or the third is that testing does not identify that a person has a substance use disorder. And the final is that a toxicology test is not a parenting test. Okay. There are now guidelines by most major medical organizations that stipulate that informed consent should be obtained prior to toxicology testing in pregnancy. This has gone as far as the United States Supreme Court in Charlestown versus the city of Ferguson in 2001, where the Medical University of South Carolina was actually obtaining urine drug tests for pregnant people in their hospitals without letting those individuals know that those tests were being obtained and then reporting them to Child Protective Services. So for public hospitals in the United States, this was ruled and deemed to be unconstitutional. Similarly, ACOG, the Society for Maternal Fetal Medicine, AAP, SAMHSA, ASAM, and many departments of public health have similarly stipulated that clinicians should obtain informed consent. What we wanted to do in a retrospective look at data across the hospital network that I practice in was really understand what's happening. What is the current practice? And so we performed a retrospective cohort study of 5 birthing hospitals that are affiliated with Mass General Brigham. We identified individuals who had underwent toxicology testing within 96 hours of delivery between April 2016 and April 2020. We extracted information on what was the indication for the test, documentation of whether consent had been obtained, the result of the test, and then whether this test was unexpected. And that unexpected result was defined as a substance not known to be prescribed or disclosed by self-report, or with a toxicology test within a week of delivery. And then identified whether individuals had a social work evaluation by a perinatal social worker prior to discharge. They had a filing to our state Child Protective Services agency called the Department of Children and Families, and then what the custody status was at discharge. We also collected some sociodemographic characteristics that are listed here. And I'm going to kind of define 3 main studies that we did using these same methods in the same data set. The first of which has been published in the past year with a really fantastic, now second-year OBGYN resident, Kathleen Koenig's leading our investigation of looking at informed consent. And I kind of gave you the punchline by showing you the title here. But let me actually describe to you what we did. So despite these state and national and even Supreme Court guidelines and recommendations, clinician adherence to consent guidelines in pregnancy remains unknown. Here's the schema of our study cohort. So there were about 60,000 deliveries in our test. I'm sorry, there's 60,000 deliveries total, not related to whether they had a maternal or infant toxicology test. Of those, about 3% had either a birthing person or an infant toxicology test. And interestingly, these tests varied by hospital. So none of the hospitals that were in our network had universal testing at time of delivery. They all used sort of a risk-based testing approach, which ranged from a little bit more than 1% of all deliveries to closer to 9%. And then the details of this are not that important, but as you can see, and I'm curious whether this is true in your hospital, there were varying degrees of whether people had a birthing person test, an infant urine, or an infant meconium, or whether it was sort of only the mom, only the infant, or both. When we looked at the just maternal tests, because at this point there had really much less discussion about infant toxicology testing consent guidelines, but we'll talk about that a little bit more as I go on. Of the 1,500 maternal toxicology tests that were sent, about 2/3 of them mentioned that the test was being obtained in any documentation that happened on the day that the test was sent. Slightly fewer than that, so less than 2/3 actually described the reason why this test was being ordered, and less than 1/3 of them documented that they had obtained consent. We can't confirm that that means that verbal consent was not obtained. So in 2 of the 5 hospitals, there were no guidelines around obtaining consent. And in 3 of the 5 hospitals, there were written guidelines that recommended or required that verbal consent be obtained prior to obtaining a toxicology test. Okay. The next thing that we did was actually try to see whether there were any maternal or hospital characteristics that were associated with documented consent after clustering to account for delivery hospital and other characteristics. And I just want to highlight 2 here. The first is that hospital policies matter. And so as you go back and you think about the hospital improvement work within your institution, in our adjusted models, while the confidence intervals were slightly wide here, we did find about twice the odds that you were going to have documentation of verbal consent if you have a policy that says that you should get it. Notably, of the testing indications, the only one that was statistically significant was that if you had a maternal medical complication being the indication for consent, you had a lower odds of having a consent. And I think there's lots of reasons that we hypothesize that this may have been the case. Thinking a little bit about kind of those women potentially presenting with more urgent clinical needs, such as someone presenting in hypertensive urgency or preeclampsia and needing to have sort of, a delivery emergently. But notably, consent was pretty universally lacking across other characteristics, including age, race and ethnicity, primary language, and income groups. So the next thing that we looked at in this same cohort is racial disproportionality. The study is currently under review, but I want to share with you what we found. What we set out here is to really understand, are toxicology tests disproportionately sent on particular groups or demographics of birthing people? And there's a long history that shows that there's disparities in toxicology testing and then reporting to child welfare, starting with a very famous, very well-cited paper in the New England Journal over 25 years ago. And since then, there's been additional kind of single-site cohorts that have looked at either mom or baby tests and found disparities. And what we wanted to do is look and understand in an updated sample, particularly in the context of a state that had legalized the use of cannabis, not just for medical purposes during our study period. What are we seeing with respect to disproportionality? Okay, I'm gonna take a quick detour and talk about racial disproportionality and child welfare in order to explain the results that I'm gonna present to you in a couple minutes. When racial disproportionality is defined as when the proportion of one group in the child welfare population, i.e. children in foster care, is proportionately larger or overrepresented or smaller, underrepresented than the proportion of the same group in the general population. Disproportionality is different than disparity. So disproportionality compares the proportion of one racial group to the same racial group in the general population. And this is assessed by something called an ROD. So essentially, we're talking about the rate of filing over the rate in the population. And I'll share some of our data with that in a second. A racial disparity is thus used to describe inequitable outcomes experienced by one racial group when compared to another racial group. And we're going to denote this by a different metric called the relative rate index, the RRI. And this is the rate of disproportionality in one population, say a Hispanic population, compared to the rate of disproportionality in Y population, say non-Hispanic populations. And I'll give you an example of data from our Massachusetts Child Protective Services Agency, the Department of Children and Families from 2021. And I'll walk you through this a little bit slowly just so that we're all on the same page. So this graph here is the race and ethnicity of individuals, and then the proportion based on, in blue, the total population, and in orange, the proportion with the 51A intake. So what you can see here is although white children make up 60% of Massachusetts. They only make up 34% of the 51A intakes. Similarly, if we take a look here and we look at Black children, they make up only 9% of the population, but they make up 10.5% of the 51A intakes. So when we come over here and we look at the rate of disproportionality, you can see that 60 divided by, or 30 divided by 60 gives you about 0.6. Similarly, 10.4 divided by 8.9 gives you a number over 1. So these numbers, the rate of disproportionality in our Hispanic and Latinx populations and Black populations is about 1. And then when we divide our, we calculate our relative rate index with the reference group being white here, you can see how you've got 1.2 divided by 0.6. So in our I have 2.0. Thanks for bearing with me while I explain that in excruciating detail. But I think this is really important in order to look at this data and then to think about, again, the unique social and legal consequences that toxicology testing has. So this is, again, data that's specific to Massachusetts. It's unpublished data from DCF that's looking at sort of the cascade from filings of abuse and neglect reports to case openings to HREs, which is home removal episode. And what is highlighted here is that Hispanic and Latino and Black children have a much higher, so twice the odds of having a abuse or neglect report compared to white children in Massachusetts. But then when you kind of go down this cascade, that disparity, that elevated relative rate index actually declines. And what our state DCF agency uses this data to claim or to suggest is that much of the disparity in our child welfare agencies or involvement actually starts at the front door, that this front door problem includes mandated reporters, including physicians and pediatricians and hospital-based social workers who are filing these mandated reports. And then they actually weed it out and you get closer to relative similar values. So I want you guys to think about the way and the role that we have as mandated reporters and as hospitals and the way that we've systematically potentially participated and contributed to the inequities and racial disparities that we continue to see with a disproportionate involvement of people of color in our child protective services systems. So here's the data that we found across our MGB system. Again, I'm going to orient you to this chart because there's a lot of numbers on it, but we looked at racial and ethnic disproportionality. So this is the ROD in the example that I gave before. In peripartum toxicology testing, social work evaluations, reporting, and then DCF custody at time of discharge. And notably, the rate of testing and similarly continue to stay elevated of social work reporting in DCF for non-Hispanic Black individuals compared to white individuals was almost twice. For Hispanic individuals, interestingly, the testing rate was elevated, was more than 1, so it was overrepresented in the social work evaluations, but then sort of closer to 1 for those that were actually discharged in DCF custody. And it was really this data combined with sort of a campaign at our institution to really think carefully about the ways in which structural racism has impacted our patients in a United Against Racism effort that allowed us to make some significant changes in our policy. So I'll get to the changes, but I have one more set, actually I have one more slide and then one more study. Okay. So you might say, okay, that's all fine and good. You just shared with me a bunch of proportions, but I want to understand whether the rate of substance use disorder in those different racial groups is the same or different. Otherwise, I can't really make sense of your data. So here's our adjusted odds ratios after adjusting for age, race, ethnicity, language, insurance, and for an ICD-10 code of substance use disorder. And I will tell you, this is messy administrative data. It's not perfect. But I want to highlight here that we found significantly elevated adjusted odds ratios of a 50% greater likelihood of having a toxicology test if you were Black non-Hispanic compared to white non-Hispanic, and a 30% greater odds if you were Hispanic and Latino compared to being white non-Hispanic. All right. final sort of exploration was thinking about the clinical yield or the utility of tox testing. So we get all of these tox tests, and what do we do with them? How often does obtaining a toxicology test result in unexpected new information? And then when it does result in unexpected new information, to what extent does obtaining a toxicology test inform our clinical management at delivery? So here's our study schematic again. These are the 60,000 deliveries that I had highlighted in the initial study. Again, we had about 3% that had either a maternal or infant toxicology test. And of those, 70% were negative for non-prescribed substances. 20% were actually positive for an expected non-prescribed substance. So we knew about it by either self-report or by a recent toxicology test or by admission right just prior to the delivery admission. And we had just under 10% with an unexpected positive toxicology test. So came in and actually learned new information by obtaining that test. The majority of those were positive for cannabis only. We decided to, for the purposes of the rest of this, given that cannabis has been legalized in Massachusetts, look at other unexpected positive toxicology tests. So there were 4% of our sample that were unexpectedly positive for a test that was for a substance that was non-prescribed other than cannabis. And this is what we found. And we divided these in a very qualitative way by tertile to sort of come up with a categorization of sort of our highest yield indications, our middle yield indications, and then our lowest yield indications. And that's the sort of red, yellow, green that you see here. And I'll highlight them for you. So the highest yield indications, so those were the ones that were most likely to result in an unexpected positive, were those who had a known history of substance use disorder with active use in the last 2 years. Interestingly, inadequate prenatal care did identify a higher rate of unexpected positives than other potential indications. And then this is also people who are receiving treatment for opioid use disorder on medications to treat those opioid use disorder with no known active substance use in the past 2 years. It's important for me to note that these indications are mutually exclusive and kind of in a hierarchy. So if you were somebody that actually had a substance use disorder who is on a medication to treat opioid use disorder, who presented with hypertensive urgency and also used cannabis, you are in this category. Here I'll show you the middle yield indications, which is that we had less than 2.5% of tests for these indications came back as unexpected if there was a maternal medical indication without these known indications above. Similarly, for cannabis, only 1.5% of those tests that were sent came back positive for an unexpected substance. And then you can see sort of the lowest yield indications here. But these are monitoring for prescribed controlled substances, like somebody who's on a stimulant for treatment of ADHD or benzodiazepine for treatment of anxiety. You can see here an infant clinical presentation, again, without any of these known above higher or middle yield indications. And then when there was sort of just an unknown indication where there was no documentation that we could figure out for why that test was sent. Cannabis is one that we're constantly talking about, and I know you are in your state as well, and so I wanted to just pull this out because we've been thinking about the utility of cannabis as an indication really carefully. So across our network, there were 614 dyads that were tested solely for the history of cannabis use in pregnancy. So not that sort of mutually exclusive hierarchy that I described to you in the slide before, but really, if the only reason, none of the other indications, but just cannabis use, how often are we likely to find a substance other than cannabis, right? So how often do we find some new information that will allow us to change our clinical management? About a third of these had a positive toxicology test. The majority, overwhelmingly, were positive for THC, so one of the metabolites of cannabis only. We identified actually several false positives. And then 7 or 1.1% were positive for an unexpected substance. 2 of those are opioids that required those infants to have additional prolonged monitoring for risk of neonatal opioid withdrawal syndrome, neither of which required a pharmacologic treatment. Okay, so jumping back to our larger sample, where we wanted to take a look at when did these tests change our management? And we thought about this in really 4 domains. When did it allow us the opportunity to provide maternal counseling or a screening, brief referral to treatment, brief intervention or referral to treatment? When did it allow us to potentially observe an infant or treat an infant for risk of neonatal opioid withdrawal syndrome? When did it change our guidelines or recommendations around breastfeeding in terms of counseling about risks and benefits? And then the final one, which I actually didn't include this data here, was around when did it change our management with respect to reporting to CPS. And what I want to highlight are these 2 boxes in red, which is that there were a bunch of missed opportunities for thinking about the clinical management of these dyads. So in 30% of the cases, there was no documentation that unexpected test either led to further screening for substance use disorder, assessing about concerns for ongoing use, and/or where they were referred to treatment. Similarly, for breastfeeding, about a third of those who didn't already say, like, no, I'm not going to breastfeed, I'm just going to bottle feed, or that they wouldn't have been recommended to breastfeed because they were positive for another substance, but a third of those, there was potentially missed opportunity to offer recommendations or suggestions or counseling around risks and benefits to breastfeeding. Okay. So now I'm going to move on to what these kind of 3 sets of studies allowed us in the course of a year-long, I will say, heated conversation with stakeholders at my hospital to think about how we would then change our policy and practice. And this is the introduction to our now revised guidelines, and I just want to share them with you, sort of verbatim, so I'll read it. The following guidelines were developed with extensive input from stakeholders at all points in the continuum of care. Recognizing the history of racial disparities in drug testing and reporting, these guidelines aim to create a standardized approach and will continue to be revised as external policies, best practices, and new data emerge. These guidelines aim to maximize newborn, child, and family well-being, to promote engagement and effective substance use disorder treatment, and to provide dignified whole family care that is equitable and trauma-informed. That was our credo. I'll share with you the changes and then we'll see how we're doing. So these are the main detailed practice changes, and I'm acknowledging sort of where we were while sharing with you now where we are. So the first practice change is that we revised our testing indication. Instead of being inadequate prenatal care, which is really very poorly and vaguely defined, to actually be that an indication for testing is if they've had no prenatal care. And you might say, okay, but Davida, like a couple slides ago, you showed me that inadequate prenatal care was on that highest list indication. So when we created these guidelines, we looked at not our hospital network, we looked at just our MGH data, and that inadequate prenatal care didn't actually yield any unexpected findings. So I think this is an area that's really fraught with potential biases and potential inequities, given that we know that there's lack of inequitable access to kind of prenatal care. But this is an area that I think there's debate about. We removed some of the common maternal medical indications for getting a toxicology test, including placental abruption to assess for risk of potential cocaine or other stimulant use. We previously had history of incarceration and a history of prostitution on our guideline, and those were removed. And we also removed a history of maternal cannabis use that is not diagnosed as a substance use disorder, so a cannabis use disorder during pregnancy. And as I know many of you know, there's differing viewpoints on what is a cannabis use disorder during pregnancy. And so we've involved our addiction consult team to have conversations with families to assess and really clinically diagnose cannabis use disorder before cannabis use is used as an indication for testing. Okay, practice change number 2. We really thought about what it means to actually obtain birth consent. And we thought about this in a lot of different ways. Where we ended after a number of conversations with our legal team and this multidisciplinary group is that we now obtain written consent for both a birthing person urine test and newborn meconium toxicology testing. So the distinction here that's really messy and hard whenever I counsel and talk with families in my prenatal consults is what happens with an infant urine. So meconium toxicology tests are basically only used to assess psychosocial risks related to maternal substance use, but they really never change my clinical management because they come back 5 to 7 days after the patient is potentially discharged. So in that situation, the consent is required. But for a urine test, which may change my clinical management in terms of thinking about recommendations about initiation of kind of breastfeeding support, as well as potential monitoring for neonatal opioid withdrawal syndrome, parental assent is required. And the final kind of big practice change that we've made is the addition of a team huddle to discuss if newborn toxicology testing is indicated where there is uncertainty. So previously there was lots of communication in sort of a non-coordinated fashion, and we've tried to institute sort of a multidisciplinary huddle, including our social work colleagues, our child protection team, as well as the newborn and sort of responding clinician to discuss indications and proceed with management. Okay. I kind of went through this, but I just want to sort of share again in sort of detail where we landed with infant urine and meconium. I understand that many of the hospitals in Colorado are using cord blood, and I think that changes this kind of calculus a little bit, but this is where we are with the use of these 2 tests. Same indications, but you can see the sort of purpose of the 2 tests are slightly different. One, infant urine is really supposed to guide our clinical management. And then meconium toxicology testing really assesses remote substance exposure, right? So meconium starts forming in the 2nd trimester, and so it can assess really remote kind of exposures up until up to 20 weeks before delivery. It can be used to determine whether the infant would be recommended for sort of more medical or developmental care, to determine if the birthing person requires more medical care or referral to treatment. And then many of our patients actually come in and say, you know, like, I want you to send that test because I want you to prove how stable I have been in my recovery during my pregnancy. But again, the major piece here, notification is required for both. But consent is not required for infant urine, but it is required for meconium. And I thought I would just share some of the language that we put into our consent documents. I'm happy to share them in more detail, but I want to make the point that consent, if you're going to move towards this, requires a conversation about risks and benefits. So it doesn't mean shove a form in somebody's face when you have 17 million things to do and just say, sign this. It really is a conversation about what the risks and the benefits of this test are. So here are some pieces that we included in our language, although actually implementing this and making sure that this happens on a provider level, as you'll see in our kind of QI data that I'm going to share, is absolutely a work in progress. Okay. So you have the right to decline a toxicology test. If you choose not to be tested, there will not be a delay in your care. However, it may delay the treatment of substance use disorder, which could increase the risk of harm to you and your baby. Test results are private, though they are visible to your healthcare team. If you do not agree to testing when it's recommended by the healthcare team, your baby still may be tested after the birth if needed. Similarly, in the infant meconium consent, I'll sort of drop down to the second bullet. A positive test, so a test that shows that your newborn was potentially exposed to substances for an unexpected substance, will prompt a discussion with your care team, and it may lead to a report to the Massachusetts Department of Children and Family. Declining to consent to this testing alone will not result in a report to DCF. If you decline this testing and there is already an existing report to DCF, this information will be conveyed to DCF. So we have to be explicit about what we do with the results of this test, because so often we hear that people were totally uninformed about what was information that was then communicated to a potential caseworker. All right. I'm going to switch over to some preliminary QI data. This is like very rough, but I think it's important to share, and I can kind of like give you a sense of where we've come over the course of the past year. So this is just very crudely when our team started to meet and rethink the guidelines, when we had actually had like a lot of interdisciplinary conversations within our own departments, but our policies hadn't been finalized because we really took a long time to come to consensus. And then this is really when our tox policies went live, sort of felt as though there was a couple months that we needed for a wash-in period, and then you can see the total number of tests completed. And that looks like it's pretty significant, but again, I want to show you this next slide, which shows you the percentage of deliveries. It's not just that like that everybody stopped delivering at MGH. This month is clearly an anomaly, but in general, you saw sort of rates of 3 to 5% before our policies went into effect, and then closer to 1 to 3% of all tests, of all deliveries resulted in birthing person or infant toxicology testing after our policies were put into place. Okay, so it looks like we're testing less, but what does that mean for the rest of our changes that we made? And this is a place that I want to highlight. This is just 6 months of data. We're working on updating this. But it turns out that kind of even after 6 months of fully being implemented and saying that we're committed to doing this and working on this, that, you know, like almost 50% of them, or about 40% of them, had no consent that was obtained for birthing person urine. And a slightly better job that our newborn team had done, but still several of them that were obtained without any consent that was placed into the chart or documented. This breaks us up a little bit more granularly. I think it's less important here, but to just note that in some cases, their consent was obtained, but we were still working on getting those written forms in place. Some people were still trying and working towards that verbal consent when the written consent wasn't done. But again, we're looking at about 40% of our birthing persons during our kind of full implementation period that were successfully had written consent, and about 75% of our newborns. This kind of shows you how we're doing over time, and I think maybe we could say that we're starting to do a little bit better, and I'm looking forward to looking at our next 6 months when we crunch it in the next few weeks. And then this is similarly same thing over time for newborn meconium testing. Okay. I thought that this was an interesting way to look at our updated indications, and then thinking specifically about whether kind of non-guideline concordant toxicology testing appeared to also be more likely to have non-guideline concordant consenting. So here were the numbers of the indications and the number of tests by indications in our updated policy. So just to, since I didn't actually say it out loud, our new policy says if you're on medications to treat opioid use disorder, that's an indication, cannabis use disorder during delivery, a history of SUD in recovery, sustained from the year prior to delivery, substance use during pregnancy, all others other than sort of cannabis, and no prenatal care, interestingly, like clinical concern by a consulting or primary team, and then a remote history of opioid use disorder, but there was concern for active use based on clinical presentation at labor and delivery. And then these were the indications that we've actually taken out of our policy. And you can see here, actually almost all of them were ones where no consent was obtained. So just highlighting the areas where we are a work in progress and still have a lot of QI work to do. Okay, one of my colleagues and friends, Dr. Ben Smith, who's a family medicine physician in Colorado, actually shared with me this maternal newborn screener that is used at his hospital. And I think it was really fascinating. I've been in the weeds of thinking about this policy change at our institution and kind of more broadly in Massachusetts. And I thought it was really helpful to zoom out and then actually zoom back in, particularly thinking about these psychosocial indications. And what I will say is I would love to kind of leave you with the question of where can bias creep into your guidelines? And particularly thinking about the ways in which we as hospital providers and clinicians, the known disparities in reporting to child protective services. When I look at some of these psychosocial indications, they feel as though they potentially exacerbate or perpetuate the disparities within the child protective services system. As we know that there are, as we heard earlier today by the beautiful family speaker, multi-generational families that have had history of child protective services involvement, that feels like a really potentially biased way of thinking about a potential obtaining a toxicology test. And again, the question is, so why are you obtaining it? How is that going to change your clinical management? I think inappropriate behavior is also just another one to think about, like how often, and we had this on our policy too, of when someone's agitated, do we potentially allow bias to creep in terms of defining that agitation? I think knowing the disparities within our carceral system and thinking about history of incarceration or current involvement in legal system, also thinking about significant or serious mental illness or housing instability, and knowing the known disparities that exist there, whether those indications, and maybe it's a call to all of you to say, well, what happens if you actually stratify your data and look by these different indications? What are you finding? How often is it giving you the result that you want? With that, here's my summary, and then I'm really looking forward to about 15 minutes together, 10 or 15 minutes to hear your experiences and discussions. So in summary, consent is recommended by all major professional organizations, even the Supreme Court, but documentation of verbal consent, in our experience in a hospital network where half of the hospitals had guidelines to say you should obtain consent, was poor. Toxicology testing is disproportionately sent on birthing people of color. And when sent, cannabis use was the most commonly invoked indication. The clinical utility of toxicology testing in a sample that used risk-based testing was low for many of the commonly invoked indications, including infant clinical symptoms, maternal medical diagnoses, and cannabis use without other known substance use disorder. That practice change in QI require coordinated buy-in and ongoing implementation efforts, even to meet guideline concordant care. And that I truly do believe that the power rests in multidisciplinary teams coming together to discuss challenging cases and listening to diverse perspectives in order to have true systems change. And I know that some of these conversations can be painful, but they're so important. And we come together as people, knowing that we have the shared common investment of family well-being, and I think that we can move together. We can move the mark together. Okay. I'm going to stop sharing my screen, and it's really sunny. Eager for any questions if you have them, or an opportunity to hear what your experiences have been in your state.
First of all, round of applause. Thanks so much, Davida. That was really, really helpful for our state and those that are here to think about what we do with tox testing, development of some sort of algorithm that we can put into place kind of uniformly across our state. As I've mentioned to you in my emails to you, it's a bit of the wild, wild west out here, right? Where I think each hospital is doing their own thing based on their local context and their understanding of what they think is best for their population. But I don't think any of our facilities sees this much larger picture, of what are the repercussions of testing, and what does that mean for certain subpopulations. So let's open it up for questions. I'll get us started. Yeah, you highlighted some of the language that was embedded into the guidelines around getting informed consent, but you also highlighted that it wasn't universally done. I mean, consent was not universally obtained. So I was wondering if you provided some training to the healthcare providers, in labor and delivery, in the NICU, so that they feel equipped in having these difficult conversations.
Right, absolutely. I think it's one thing to change a guideline, but implementation is an entirely different bucket. And that's where I think we realized after 6 months of doing this work that we have a long way to go. So we're in the process of working with a really phenomenal MFM fellow named Molly Sequel, who's kind of helping us to script some conversations about having these conversations in order to be able to offer both newborn providers as well as prenatal providers or those on labor and delivery to have these conversations. Yeah. Thank you for that question.
Question in the back, probably from the chat. Uh-oh. In developing this policy. Oh, thank you.
Okay, I'll repeat that. Can you discuss whether there's uniformity across the partner system and how your team interacted with legal in developing this policy?
Yeah, so I am part of a hospital that is a hospital network, which I think is what you're referring to in terms of partners. It's changed its name to Mass General Brigham, which is the MGB that I reported a couple times. Lots of lingo, doesn't matter. But for purposes of our policy, it's hospital specific. And so we created all of that to change our MGH policy. We worked really closely with our Office of General Counsel in order to kind of review and think about the legal implications for families. And we're hoping to create a unified now sort of network level policy across Mass General Brigham, but we're not there yet.
Working. Oh, good. Okay. Hi, first, thank you so much for the presentation. I think it was great. One thing I wanted to, and I may have misheard or just clarify here that, so all of the patients in this research study were being tested at delivery hospitalization. Is that correct? So did you account for any of this if they were tested throughout pregnancy, like at their first prenatal care visit? And if so, like how that impacted your results, particularly around, I think you had said that you found that, there was a lack of referral to treatment services and things like that. But if they had been tested earlier, were there earlier missed opportunities for that as well?
Yeah, I think ACOG has been really clear on its guidelines to do exactly what you just said. So test at that initial, screen at that initial prenatal visit, and can then have a further discussion whether testing is indicated. We decided to highlight peripartum toxicology testing at delivery because there's this very, very highly prevalent use of it. There's many centers that are actually moving towards universal toxicology testing at time of delivery. And I would agree with you. And I'd argue that same thing, that like if the goal is to identify people who are in need of treatment, if it's going to try to change our clinical management of these patients, then the need is to really identify them as early as possible. And that first trimester visit's the most important one, and delivery is too late. We didn't, in our sample, look back at how well we were doing with screening and then potential referral to treatment in the outpatient setting, although it's an important question, and I encourage you to look at it within your networks. It's so fun to now see you all. That's the best.
Hi, I'm just curious about your state's child abuse and neglect laws. Does it currently require all reporters to report positive toxicology tests? Is it testing based, or is it moving away from testing based like ours has? Because our current state laws have moved away from the requirement of a test being like the impetus to actually then report.
Yeah, we're behind where you are right now, and that the guidance that we've had has actually not been updated since we've had legalization of cannabis in our state, and there is very much still circular level guidance from our Department of Children and Families that says evidence of prenatal substance exposure, and specifically highlights the use of medications to treat opioid use disorder, which is something that I can rant about for a long time in another setting. Is an indication for a report, which I think is unjust and discriminatory.
Yeah, I agree. And I'm just curious how this is going to impact our state moving forward, since in the past we've kind of put so much attention on those toxicology tests, and how's that going to impact, where our child welfare system will go eventually. So I'm hoping to figure some of that out through this process.
There's a related question in the chat I might build on. So it says, how do you respond to hospital-based staff who feel uncomfortable moving out of the, quote, rather safe than sorry approach to child welfare reporting?
Yeah, I think it's a really good question. I think this is where having your hospital-based teams understand the history of our child protective services agencies and the history of systemic racism amongst them across the country is actually really important here. As is potentially hearing about individuals like Ms. Smith who feel like there had been real harm that had been done because of potential involvement. And I think work that I've been doing ongoing and qualitatively listening to women's experiences is that test that causes even investigation causes intrusive and invasive harm into people's lives, even if that investigation does not lead to an open case. If that open case is opened, it really disrupts the sort of normal parenting experience for that family. And one of the kind of most profound quotes that I've been kind of sitting with and trying to grapple with as a pediatrician who cares for families impacted by substance use as my clinical practice was somebody who told me that the scariest place for her to go as a person in recovery with an open DCF case is her doctor's office. And so every time she comes to see me, she knows that there's the potential that that means that she could walk away where somebody has filed a 51A or a child protective services report to her. And I think until we somehow figured out how to regain the trust that we should have with our patients, like we're going to continue to have this mismatch and disconnect, and people are going to continue to avoid prenatal care. So I think when someone says better safe than sorry, I would have a conversation with them about what we're trying to be safe about, and then think about what are the ways that we really assess parenting or risk of child abuse and neglect. And I would go back to that argument that actually is really beautifully laid out in several documents by the National Center of Child Abuse, Substance Abuse, and Child Welfare, that a toxicology test is not a parenting test. So we need other evidence to identify ways to support families or assess families about risk than a toxicology test.
Thank you, Davida, for your data and all your work on what you're doing with your families in your state. In my particular case for James and I, we got involved because there was an anonymous report from a refusal of a toxicology test. I did initially denied having a test done. Before that 2 months, my son was born. And upon refusal of that test, I became involved. That cast was already looked at as far as, well, possibly these parents may be using or under the influence. However, nevertheless, they were right. But with that being said, I think the work that we can think about and acknowledge is maybe Colorado, and then in other states like yours, we can start working with possibly looking at putting a peer navigator side by side with parents in doctor's offices during labor and delivery visits, and just talk about, whether or not their discussion is going to be voluntary, their statement is going to be voluntary at that point. I think that would diffuse the situation with whether or not cases will be open and filed as a DNN in our state, and then what you call it in your state. So just putting a peer navigator and a lived experience person in that space with people that are going through it would be helpful.
Thank you for that suggestion and recommendation. I think the way that I've been thinking about my ongoing work in this space is how to create systems of support rather than surveillance. And so everything that I'm doing and trying to think about the care of families postpartum is what does it look like to support rather than surveil, and how can we sort of flip that on its head? And I think peer navigation and peer support is a really wonderful way to do that. But our bigger systems need to change. Otherwise, we're putting that peer in a potentially traumatizing situation of being re-traumatized all over again by experiencing the harms of our system.
A note, and then another question from the chat. So just a note about some work that's also happening in Colorado from Jessica Thast with the Colorado Department of Public Health and Environment. She just wanted to share that the Support Colorado Policy Analysis Work Group has been working for the past year on creating best practice guidance on toxicology use. And that the hope is that this document will be a support to Colorado hospitals and providers in becoming more consistently and equitably implementing the use of tox tests. And if you're interested in learning more or getting involved in that work, folks can reach out to Jessica. And so folks that are virtual, you see her email in the chat. Folks that are in person, feel free to find either Kelly or myself, and we can make sure that you get connected. And it's getting close to being ready for review by a wider audience of stakeholders outside of the work group. So more to come on that soon. And then back to another question. So Davida, do you have a screening tool in your electronic medical record? And how do you document consent and indication of screening in your electronic medical record?
Yeah, first off, it's so awesome to hear about the ongoing work, and I'd love to hear about what you guys come up with when you've finalized that work as well. We use the NIDA Quick Screen as our single question screener across the entire hospital, and then that will default, depending on what the answer is, to sort of a further screen or assessment. In terms of the consent, we have a written consent form that gets uploaded in our EMR in a very non-technologically savvy way into a media tab that likely, is only visible several days after the patient's been discharged. So it's not perfect. What we're working on and what I'm really hopeful for is actually a button that will be a hard stop in ordering the test before the consent is obtained, similar to the way that some of your institutions may do HIV testing. So what we're going to ask is, before you are able to order a toxicology test on our labor and delivery unit or on our postpartum newborn family unit, that you'll have to say, was consent obtained, and then the person that obtained it prior to the order being placed, which we hope will help with some of the ongoing implementation work that we're doing.
Awesome. And one more question from the chat that I'm seeing, and lots of thank yous in the chat as well. But could you talk a bit more about the workflow and process of the multidisciplinary team check-ins when in doubt about whether to administer a tox test?
Yeah, I think they're really variable, and I've been thinking a little bit about how to make, what's the checklist to make these feel like they have a structure and a format to go well. So I'll say it's a work in progress, and I'd love to learn and to think about it with all of you. I've been learning a lot from my colleagues at UCSF, who created what they call a DCF timeout. This is actually they have created this document where they say they actually recognize the harms that a filing can have on a family and want to make sure that all of the teams are in line and in agreement before a filing happens. We're not quite there in our hospital, but I would encourage you to sort of, I can share what I've learned from them. And I think the key is to have as many players, people, providers, clinicians, all together in the same space. I think Zoom makes this easier. It was really hard to figure out how to get everybody in the room to talk about it in real time, but we can actually very quickly hop on a 5-minute Teams in passing, despite everybody's busy days. And so the goal is to get a clinician or person who knows the birthing person, somebody who's responsible for the newborn, usually the social worker, obstetric social worker who's involved in the case, often a nursing director, and then our child protective services, our child protection team.
Questions? I did have a comment, one of your last slides where you shared the indication for testing that did occur included a number of medical conditions, right, of the neonate as well as maternal complications. I'll just highlight that a lot of those complications, in fact, are overrepresented in our Black population. So when I think about small for gestational age, a far larger number of our Black infants are small for gestational age or intrauterine growth restricted. And so just by that alone, you will have an over-testing of Black infants. As well, we know that preeclampsia, as well as a number of other perinatal complications, are much more highly prevalent in our Black birthing population. And just by that sheer few lines in that algorithm, you've already set us up to do over-testing of Black infants and mothers. So I think your point, Davida, of how systems are created perhaps unintentionally, that we think with what we think will lead to better outcomes, in fact, can cause harm. Davida, we really appreciate you. Thank you so much. And we hope that we can actually meet you in person perhaps next year.
Thank you guys for the work you're doing. Such a pleasure to be here. Bye, everybody.